If you've ever opened a junk drawer, and we all have one,
Yeah.
and pulled out just a massive tangled knot of old power cords and headphones, you know exactly what your first instinct is.
Oh, absolutely. You just want to yank them apart.
Right. You try to pull the wires apart.
Yeah.
But the harder and faster you pull, the tighter that knot actually gets.
Yeah, it just makes it worse.
It really does. And if you are listening to this right now, whether you're, a healthcare student trying to understand neurocognitive decline, or maybe a caregiver who is just feeling completely overwhelmed by a loved one's behavior, you probably know that pulling on the knot doesn't work.
No, it really doesn't.
So today, we are taking a deep dive into the source material to figure out why applying standard logic and reasoning to a brain affected by dementia is exactly like pulling on those tangled wires.
Yeah.
I mean, the harder you argue, the tighter the knot gets.
It is, it's an incredibly painful dynamic to experience. I mean, you can see clearly what needs to be done or what the truth is, but your normal approach to communicating just makes the whole problem worse. The resistance builds up, the agitation spikes, and ultimately, nobody feels heard.
Yeah, which is so frustrating. So our mission today is to completely unpack the mechanics of dementia and Alzheimer's disease. We're going to look under the hood at what is physically breaking down in the brain, and then how to radically adjust the way you communicate to bypass that damage.
And we'll also be looking at what medical and palliative care actually looks like at the end of life.
Exactly. We want to replace that frustration of the tangled wires with some deep clinical understanding. But before we can talk about how to care for someone, we have to define what we are actually dealing with. We use the word dementia constantly, but it isn't just one single disease, is it?
No, not at all. And that is probably the most common starting misconception. Dementia is not a disease in itself. It is a clinical syndrome.
Okay, so what does that mean practically?
You can think of it as an umbrella term. It describes a chronic, progressive decline in cognitive function that is severe enough to interfere with daily life. So underneath that broad umbrella, there are actually many different specific diseases causing that physical brain damage.
And Alzheimer's is the most common disease under that umbrella, right?
By a wide margin, yeah. Clinical experience shows Alzheimer's disease accounts for about 60 to 80% of all dementia cases. And to really understand the behaviors we see, we have to understand what is physically happening in an Alzheimer's brain.
So what's actually going wrong in the hardware?
Well, it's characterized by two main pathological changes. First, you have beta amyloid plaques. These are basically sticky protein fragments that build up in the spaces outside and around the neurons.
Okay, wait, let me make sure I'm tracking here. Because neurons don't actually touch, right? They communicate across a tiny isomes. So are these plaques essentially gunking up that gap?
That's a great way to visualize it, yeah. They physically block the chemical signals from crossing the synapse, so the whole communication network starts to break down.
Wow.
But that's only half the problem. The second hallmark is tau neurofibrillary tangles.
Tangles, okay.
Right. And unlike the plaques, these tangles form inside the neurons themselves. Healthy neurons are supported internally by these structures called microtubules, which kind of act like railroad tracks transporting nutrients.
Okay, so the tracks deliver the food.
Exactly. But in Alzheimer's, the tau protein collapses into twisted tangles, the railroad tracks disintegrate, and the cell literally starves to death from the inside out.
Oh my gosh. So between the plaques blocking the signals outside and the tangles starving the cells inside, you have just massive cell death.
Yes, massive. And over time, this cell death causes the actual brain tissue to atrophy. I mean, the brain physically shrinks, the grooves deepen, and the overall tissue mass decreases dramatically.
That is wild to picture. But if Alzheimer's is 60 to 80%, what else is under that umbrella? Because I imagine different physical damage creates a totally different clinical picture.
It absolutely does.
Right.
So you also have vascular dementia, which is caused by problems with the blood supply to the brain, often from small vessel disease or maybe a series of mini strokes. The brain tissue dies from lack of oxygen.
Okay, that makes sense.
Then there's Lewy body dementia, which presents very differently. It's often characterized by visual hallucinations like people often report seeing small children or animals along with REM sleep behavior disorders where people vividly act out their dreams.
Oh, wow.
Yeah. And it also features Parkinsonism, meaning physical symptoms like resting tremors, muscle stiffness, and sort of a shuffling gait.
So if a family member is having vivid hallucinations and severe stiffness, a clinician might lean toward Lewy body rather than Alzheimer's.
Correct. And then you have frontotemporal dementia, which typically strikes younger people, often in their 50s or 60s.
Now that
Yeah, it's tragic. And because it attacks the front and sides of the brain first, the earliest symptoms aren't usually memory loss. Instead, you see drastic changes in personality, a complete loss of inhibition, or severe difficulties with language.
that has to be so jarring for the family.
It really is. However, a crucial fact we know from clinical experience and autopsy studies is that pure, isolated forms of these diseases are pretty rare, especially in people over the age of 80.
Really? So what do they actually have?
The most common reality is mixed dementia. That's usually a combination of Alzheimer's pathology and vascular disease simultaneously.
Okay, I want to pause here because I'm thinking about the listeners who might have aging parents.
Mhm.
What if you have a patient, say an 82-year-old, who has been totally sharp, living independently, and then suddenly over the course of just 2 days, they are wildly confused, hallucinating, and they don't know what year it is? Does dementia ever just hit you overnight like that?
I am so glad you asked that because this is a massive issue in geriatric care. We have to differentiate between the 3 Ds here. That's dementia, delirium, and depression.
Okay, the 3 Ds.
Right. What you just described, a rapid, sudden onset of severe confusion, is not dementia. That is delirium.
Interesting. So how does the underlying mechanism of delirium differ from the brain shrinkage we were just talking about?
Well, dementia is chronic, progressive, and structural. It takes years for those plaques and tangles to build up. Delirium, on the other hand, is an acute state of confusion. It is sudden, temporary, and usually reversible.
Reversible. Okay, that's a huge distinction. What causes it?
It happens when the brain is subjected to extreme physiological stress. In older adults, their physiological reserve is much lower, so something as simple as a urinary tract infection, a UTI, or a minor electrolyte imbalance can cause systemic inflammation.
Wait, a UTI can make someone hallucinate.
Oh, absolutely. That inflammation crosses the blood-brain barrier and disrupts brain function, causing severe delirium that looks identical to advanced dementia.
So treating the underlying infection like just giving antibiotics for the UTI
Yeah.
actually clears up the confusion.
Exactly. Once the medical stressor is resolved, the delirium lifts.
Wow.
And the third D is depression. In older adults, severe depression doesn't always look like sadness. It can manifest as profound apathy, difficulty concentrating, and memory issues.
Really? Just memory issues from being depressed.
Yeah, it's sometimes called pseudo-dementia. Their cognitive processing slows down so much that it mimics a neurocognitive disorder. But again, treating the depression can resolve those cognitive symptoms. Getting the diagnosis right among those 3 Ds is critical.
That distinction is incredibly helpful. So going back to the dementia umbrella, the chronic structural breakdown, how does this actually show up functionally? Because, I mean, we tend to just think of it as forgetting where I put my keys.
It goes so much deeper than that. To help categorize the functional losses, clinical practice often refers to the A's of Alzheimer's.
Okay, let's go through 'em.
The first is amnesia, which is the short-term memory loss resulting from damage to the hippocampus. The brain physically loses the ability to convert short-term experiences into long-term storage.
Like asking what's for dinner, getting the answer, and then asking again 5 minutes later because the memory was never recorded.
Precisely. It's just gone. The second A is aphasia.
Yeah.
This is damage to the language centers. It's the inability to understand or create speech.
So they might know what they want to say but can't find the word.
Yes, they might have the word on the tip of their tongue but can't access it. Or the words you are speaking might just sound like a foreign language to them entirely.
That sounds terrifying. What's the third one?
The third is agnosia. This is a sensory processing failure in the parietal and occipital lobes. It's the inability to recognize objects, people, or even the purpose of things.
Can you give an example of that?
Sure. So, for example, their eyes perfectly see a toothbrush, but their brain has lost the concept of what a toothbrush is used for. They might try to write a letter with it.
Wow. That is a profound disconnect. It's not just memory loss, it's concept loss.
Exactly. It's losing the meaning of the world around you. And the fourth A is apraxia. This involves the motor cortex. It is the loss of motor skills and the ability to perform purposeful, sequential movements, even though their muscles are perfectly strong.
So they just forget how to move.
Basically, yeah.
Huh.
They simply forget the physical steps to tie their shoes, button a shirt, or eventually even how to walk.
I'm trying to visualize this. It's almost like your brain is a giant filing cabinet. Amnesia is just losing the files. But aphasia, agnosia, and apraxia, that feels like the actual drawers of the cabinet are being glued shut. The physical hardware is locked down.
That is an excellent analogy. The information might even still be in there, but the hardware to access it is destroyed. And as those drawers glue shut, the disease follows a specific trajectory.
Right, from mild to severe.
Yeah. In the mild stage, you see the short-term memory loss and subtle functional changes. In the moderate stage, which is usually the longest, you see major safety issues, wandering, aphasia, and major behavioral shifts. Finally, in the severe or late stage, the patient becomes bedbound, largely nonverbal, and totally dependent for all basic care.
But the day-to-day progression of this isn't a smooth decline, is it? I've heard caregivers say their loved one was fine for months and then suddenly got drastically worse.
That is a fascinating insight we get from hospice care. Caregivers often expect dementia to decline on a smooth, downward ski slope. But it doesn't. It's a staircase.
A staircase. Okay, how does that work?
A patient will plateau and seem stable at a certain baseline for a long time. Then, suddenly, they experience a sharp drop in function, often triggered by a minor stressor like a fall, a change in environment, or a minor infection. They drop a step.
And do they ever get that step back?
Sometimes a little. When the infection clears, they might recover back up half a step, but they rarely return to their previous baseline. Then they plateau again at this new, lower level.
For those of you navigating this with a family member, that has to be terrifying. You think they're stable, then a sudden drop makes you think it's the end, only for them to stabilize again at a slightly lower capacity.
It causes immense anxiety. But understanding the staircase rhythm helps caregivers anticipate the reality of the disease, rather than constantly feeling blindsided.
Okay, I want to shift gears to how we actually communicate with someone in the moderate stages. Because if those physical drawers in the brain are glued shut, our standard ways of talking to people must completely fail.
They absolutely fail, and this brings us back to the physical anatomy of the brain. In many types of dementia, particularly Alzheimer's and frontotemporal dementia, the frontal lobe is heavily damaged, and the frontal lobe is basically the CEO of the brain.
So it's in charge.
Right, it controls executive function, logic, reasoning, impulse control, and the ability to sequence information.
So if a family member sits down and tries to reason with a patient like saying, "Mom, you can't drive anymore because your vision is bad and you've had 3 fender benders," we are appealing to a CEO that is no longer in the building.
Exactly. Clinical research provides a very powerful analogy here, which is the broken headphones.
Ooh, I like that. Tell me more.
Trying to use logic and reasoning with a dementia patient is like trying to help someone hear music through broken headphones by simply turning up the volume.
Oh, wow.
It doesn't matter how loud you turn the volume, how beautifully you argue, how clearly you explain, or how much evidence you present. The headset is broken. The signal is physically not getting through. All turning up the volume does is cause pain, frustration, and agitation.
This means that some of our most natural, deeply ingrained human instincts for helping people are actually massive triggers. For instance, what happens when we tell someone who is confused to just calm down?
Telling someone to calm down is incredibly invalidating, even for a healthy brain. But for a dementia patient, it is disastrous. Imagine being terrified because you genuinely believe you are late to pick up your children and someone just tells you to calm down.
Right, it minimizes their very real terror.
Exactly. It triggers instant defensiveness.
What about rushing them? I think of busy nurses on a unit or a caregiver trying to get their parent to a doctor's appointment. Come on, we're going to be late.
Rushing them is one of the most common mistakes. A brain with dementia has a drastically slower processing speed. When you rush them, you are flooding a damaged system with too much input.
And what happens then?
It immediately triggers a sympathetic nervous system response: fight, flight, or freeze. They might lash out and yell, or they might just freeze and stare blankly at you. Slowing down your speech and your physical movements isn't just about being patient, it is a clinical intervention to regulate their nervous system.
Okay, I want to push back on something here because I genuinely struggle with it ethically. Let's say a patient is standing by the door, highly agitated, and says, "My mom is coming to pick me up." But you know, their mom passed away 20 years ago. Isn't a nurse or a family member essentially lying to them if they don't correct them? Aren't we enabling a delusion by not telling the truth?
It feels incredibly counterintuitive, I know, and it goes against every instinct we have, to be honest, but we have to look at the neurology of what happens when you correct them. The memory center, the hippocampus, is damaged, but the emotional center, the amygdala, is often still very intact.
Okay, so the emotion is there, but not the memory.
Exactly. So if you tell them your mom is dead, they do not have the stored memory of her dying. You are breaking the news to them for the very first time.
Oh, wow. So they experience the raw, visceral trauma of that loss as if it just happened this very second.
Yes. You are inducing fresh grief and trauma, and here's the truly tragic part. 5 minutes later, their damaged hippocampus will forget the fact that you told them she died.
But the feeling stays.
Yes. Their amygdala will hold on to the emotional payload. Their body will still be flooded with cortisol and adrenaline. They will be devastated, agitated, and weeping, and they won't even know why.
That completely changes how I view this. So if correcting them causes actual harm, what is the alternative?
The clinical rule is connection over correction. You validate the underlying emotion, and then you redirect. If they are waiting for their mom, the underlying emotion is usually a desire for safety or comfort. You step into their reality.
How do you do that?
You say, your mom is such a wonderful person. What is your favorite thing about her? You connect with the emotion of missing her. Then, after a few minutes, you redirect. While we wait, could you help me fold these towels?
You validate and redirect. So if a patient is furious because they think aliens stole their sandwich from the fridge, you don't argue about the existence of aliens or point out they ate the sandwich an hour ago.
No, absolutely not.
You just say, I'm so sorry your sandwich is gone. That is so frustrating. Let's go to the kitchen. I'll make you a fresh one.
Yes, exactly. You validated their distress and offered a solution. Logic comes last, or not at all. Another key communication shift involves decision fatigue.
Right, asking too many questions.
Yeah, caregivers often ask open-ended questions out of respect. What do you want for lunch? Or what do you want to wear? But open-ended questions require massive executive function searching memory, weighing options, sequencing steps. It causes cognitive overload.
So what's the better approach?
Instead, offer forced binary choices. Would you like soup or a salad? Just keep it simple.
So if we can't fix their reality with our words, how do we physically manage their environment to keep them safe? Especially when it comes to things like sundowning. What exactly is happening there?
Sundowning is a clinical phenomenon where confusion, agitation, and restlessness spike in the late afternoon and early evening. Research suggests it's linked to the physical degradation of the brain's suprachiasmatic nucleus, which controls our circadian rhythms.
So their internal clock is just broken.
Essentially, yes. And as the sun goes down and shadows lengthen, their damaged visual processing, that agnosia we talked about earlier, misinterprets the shadows as threats.
Oh, that makes so much sense.
Oh.
So what are the interventions?
Interventions include turning on all the bright lights in the house before dusk hits, maintaining a strict daily routine, and avoiding overstimulation or caffeine late in the day.
And beyond lighting, the physical safety of the home has to change completely, doesn't it?
Drastically. Scatter rugs are one of the biggest hazards and need to be completely removed to prevent catastrophic falls, especially as apraxia affects their gait. You have to hide car keys.
What about wandering? That's a huge fear for families.
For wandering, a highly effective environmental trick is placing door locks out of the normal line of sight, either very high up on the door or very low down near the floor. Their visual field narrows, so if they don't see a lock at eye level, they often just won't figure out how to open the door.
Let's talk about the medical side of this. If the physical structure of the brain is failing, can medication stop it?
Currently, there is no cure for most forms of dementia, but we do have pharmacology to manage the symptoms. The two primary classes of medications are cholinesterase inhibitors, like donepezil, and NMDA receptor antagonists, like memantine.
Walk me through the mechanism there. How do they actually work in the brain?
Well, neurons use a chemical messenger called acetylcholine to form memories and process thoughts. In Alzheimer's, the neurons that produce acetylcholine are dying.
Okay, so there's a shortage.
Right. Now, the brain naturally produces an enzyme called cholinesterase, which acts like a cleanup crew to sweep away used acetylcholine. Donepezil works by blocking that cleanup crew. It prevents the breakdown of whatever small amount of acetylcholine is left, keeping it in the synapse longer to boost communication.
And what about the other one, memantine?
Memantine targets a completely different pathway involving glutamate. Glutamate is an excitatory neurotransmitter. It's sort of like the spark plug for learning. But in Alzheimer's, damaged cells release toxic, excessive amounts of glutamate.
Too many spark plugs firing at once?
Exactly. This causes too much calcium to flood into the neurons, literally exciting them to death. Memantine acts as a shield, blocking that excess glutamate and preventing that excitotoxicity.
So these medications aren't reversing the damage. It's sort of like putting sandbags around your house during a rising flood. You're holding the water back, minimizing the damage to the living room for as long as you can, But the storm is still raging.
The sandbags analogy is perfect. We are just buying time.
And I imagine those sandbags come with side effects.
They do. Cholinesterase inhibitors commonly cause gastrointestinal upset like nausea and diarrhea. More seriously, they can cause bradycardia, a slowed heart rate, which increases the risk of fainting and falls.
Which brings us to the hardest part of this deep dive. Eventually, the floodwaters rise above the sandbags. What does the severe end stage of this disease actually look like? And how do medical professionals handle it with dignity?
The end stage of Alzheimer's is physically devastating. The general rule of thumb in palliative and hospice care is can't walk, can't talk, can't eat.
Just a complete shutdown.
Yes. The patient becomes entirely bedbound. And when the body stops moving, the cardiovascular system prioritizes the core organs. Blood flow to the periphery decreases, meaning the skin, which is the body's largest organ, begins to fail.
So you see a lot of skin issues.
Exactly.
Yeah.
Despite meticulous nursing interventions like turning the patient every 2 hours and floating their heels, skin breakdown and deep pressure wounds are incredibly common. It is a physiological sign of the body shutting down.
And the inability to eat, is that the apraxia we talked about earlier? Like the brain forgetting the motor sequence.
Exactly. They develop profound dysphagia difficulties swallowing. Swallowing is a complex coordination of cranial nerves and muscles. When the brain forgets that sequence, food and liquid go down the wrong pipe into the lungs.
And that leads to pneumonia.
Yes. This causes aspiration pneumonia, which is actually the most common ultimate cause of death in Alzheimer's patients.
For a family member watching this, the instinct must be, we have to feed them. Can we put in a feeding tube? How does a care team navigate that?
This is where palliative care philosophy is so vital. The primary clinical advice at the very end of life is, let the body be the guide.
Let the body be the guide.
Right. We do not force feed. Putting a feeding tube into a dying body that can no longer process nutrition often causes fluid overload, edema, and more distress. If the patient wants a bite of ice cream and can tolerate it, wonderful. If they refuse, we let it go.
It's about comfort.
Completely. The entire focus shifts away from prolonging life and moves strictly to symptom management, treating pain, easing anxiety, preventing breathlessness, and ensuring absolute comfort.
I just think if you are a burnt-out caregiver who has spent years fighting to get your loved one to eat, to bathe, and take their meds, hearing a medical professional say, let the body be the guide, must feel like an overwhelming permission to finally stop fighting a losing battle and just focus entirely on love.
It truly is. It lifts an immense burden of guilt off the family. It allows a daughter to just be a daughter again, or a husband to just be a husband rather than a taskmaster.
Let's pull all of this together. Dementia is the umbrella syndrome, with Alzheimer's physically shrinking the brain via plaques and tangles. We have the staircase progression of drops and plateaus, not a smooth slope.
Right.
When communicating, we have to recognize that the headphones are broken. Frontal lobe is damaged. So we drop the logic, avoid open-ended questions, and prioritize connection over correction to avoid triggering a damaged nervous system. And finally, at the very end, we step back and let the body lead the way.
The profound practical value of this knowledge is that it takes the chaos of dementia and gives it a framework. I mean, whether you are a bedside nurse or a family member, understanding the why behind the behavior transforms your frustration into targeted, compassionate action.
And as we wrap up this deep dive into the sources today, I want to leave everyone with one final thought. We spent this entire time talking about how to stop pulling on those tangled wires.
Which brings up a really powerful consideration. We spend so much of our time, energy, and frustration trying to pull people with dementia back into our reality. We desperately try to make them conform to our timeline and our facts.
It's exhausting for everyone.
Exactly. But what if we completely let go of that need? What if we fully, bravely stepped into theirs? Imagine how that could change not just dementia care, but how we deeply connect with anyone in our lives who is experiencing a reality different from our own.